Go. Good evening, ladies and gentlemen. Welcome to yet another session of Thoracic Gurus. And it's my honor and privilege to invite today's guru, who is indeed one of the senior cardiothoracic surgeons in India. He is the first one in Kerala to have started coronary artery surgery. He is also the first one in Kerala to have started thoracoscopic surgery. And the whole program is going from pillar to pillar, and they're really doing great work. I have known him for the last about 10, 12 years, and I've always been impressed with his knowledge about the subject and his clarity of thought, especially when he discusses the finer points of thoracic surgery. So you are very, very fortunate, all of you, to actually get to interact one-on-one with Dr. Nasser Yusuf. Dr. Nasser Yusuf, on behalf of all the surgeons of the country, may I welcome you to this forum, and thank you very much for agreeing to give a talk on this very important topic. The floor is all yours. Take it away, sir.
Thank you very much, Dr. Khan. It's been a pleasure knowing you all these years. And what struck me most was your innovative, enterprising thoughts and the way you are vibrant, which clearly reflects in this meeting, seminars that you have organized. Can you hear me, Dr. Khan?
Yes, I can hear you. I will be switching off the participants as they log in. Can I please request everybody to please log off your microphone as soon as you get into the room? Thank you. Carry on, sir.
I need to share with you where this talk is coming from. This is my thoughts over the years which have developed, and the message I strongly believe is believe nothing, no matter where you read it or who has said it, not even if I have said it, unless it agrees with your own reason and your own common sense. To know your enemy you must become your enemy, said Sun Tzu. He was a general in the Chinese army 500 years before Christ. We're talking about 2,500, and he's supposed to be the greatest military strategist. Why do I quote him? We have bronchiectasis, especially when you go in for treating a disease. We need to know it, have maximum information about the condition. For this, we need to know our basics, our pathology, and then can we know or decide what is best for the treatment and what are the guidelines. Many guidelines come in, but as you know, guidelines are human-made. They are the thoughts of a group of people, respective people. However, many of times we have critical appraisals, and you need to think whether what is stated agrees with your thinking or logic. Now let's get to bronchiectasis. The basic definition: abnormal permanent dilatation. Important note for surgeons is it's permanent dilatation of subsegmental bronchi due to irreversible distortion of the elastic and muscular layers of the bronchial wall. So said Laennec more than 200 years ago. Next, bronchi and bronchioles involved in a vicious circle of transmutable infection and inflammation with mediator release. This is important. This is the key. Now comes a third statement, which says the incidence varies between 3.7 to 52 per 100,000 adults. Different studies. And why the difference? Because what comes out from the developed world and what comes out from the lesser developed world, the statistics are quite varying. So much so If, for example, in the United States, if a disease is less than 200,000, if it affects less than 200,000, they dismiss it and call it, the inverted commas, orphan disease. So diseases which do not matter to the developed world is what is known as orphan disease, but it does matter to the majority of the world, which is the developing world. And so it is not an orphan for us. It is equally important as any of the major conditions which they in the West look at. Talking about the vicious circle, it's not so difficult. It's a bronchial wall inflammation and destruction, primarily by bacteria, which affects the impaired mucociliary clearance. So there's pooling of secretions, there is bacterial growth happening there, and it becomes a reservoir of bacterial infection. This in turn causes airway inflammation, which persists, and the circle of bronchial wall inflammation and destruction continue. Yes, of course, the host's defense is a major player. We need to look at the etiology of bronchiectasis, congenital, which interests the pulmonologists, which interests the pediatricians, which interests the physicians, is important to us to just be passingly aware of these conditions. And the only role for this is basically medical management. And thereafter, if it is surgery, it comes to lung transplantation, though primarily doesn't bother us thoracic surgeons, congenital causes. However, you look at the acquired causes. Yes, this is exciting. Infection, which comes first in the list, is very significant. The bronchial obstruction, lower down, if there's a tumor or a foreign body long-standing, can cause distal destruction, extrinsic enlarged lymph nodes, fancifully called the middle lobe syndrome or Lady Windermere's syndrome, which sits on the takeoff of the middle lobe bronchus. Then, of course, which interests us in India and in China, is scarring secondary to tuberculosis, pneumonia, pertussis, and serious rubella infections. So when you examine the causes of non-cystic cystic fibrosis we don't deal with, the important thing is you note it's post-infectious, 29 to 42%, and the rest, 50%, is idiopathic. Idiopathic, we really do not know the cause. The other long list, what you see, is basically for completion's sake. So idiopathic does form a large group, and post-infectious is what is the problem in acquired. And let's look at the organisms. This chart reads it off. Pseudomonas in this is the most dangerous. I shall tell you why in a moment. And at times, when you look down on this screen, you go down to no organism not specified. Many times you know the patient has infection, but no organism is isolated. But it's nice to know these are the common organisms so that you can select an antibiotic suitable, which will cover a broad spectrum, but importantly cover Pseudomonas, Klebsiella, and the ones mentioned here, if possible. Now, although it is widely believed that there has been overall decline in incidence of bronchiectasis, and why is it so? Due to more effective treatment of childhood respiratory conditions. So they hit it hard in childhood, so chances of the sequelae happening is much reduced. Successful vaccination programs, again, and strategies for the control of pulmonary tuberculosis, yet although the numbers have declined markedly in the West, it hasn't so much so telescoped in the developing world. Now let's look at the way it presents. You're aware of it, chronic cough, expectoration of foul-smelling purulent sputum up to about 250 to 500 ml per day. Imagine somebody coughing it persistently, continuously, all the time, and cap it with hemoptysis, difficulty in breathing, repeated episodes of Recurrent tract infection requiring hospitalization multiple times in a year, what do they become? Bronchiectasis becomes a social stigma. The patient is isolated, there's loss of self esteem, becomes introverted, intrinsically depressed, low social support, and finally a social discard. He's, in other words, living dead. Now let's take off from the social aspect and get down to the more pathological aspect. What you see here in this picture are the most virulent and dangerous, harboring the maximum amount of secretions is the cystic ones, appears like small sacs. Next to that, you have the varicose ones, which we are very familiar with the varicosities in the legs, very similar. These two are amenable to surgery. This is reportedly normal. And this is the cylindric, the third type of bronchiectasis. This is not amenable to surgery. Surgery can be done, but we don't get the benefit. The only thing what you see is the difference here. The dilated bronchi go almost up to the pleura. Here, there is perfusion. It's supposedly due to bronchial perfusion. Here, these areas are hypoperfused, varicose and the cystic. Surgery does help here because it takes off this destroyed part of the lung. So you have saccular bronchiectasis or cystic bronchiectasis caused by infection. Now we know the important cause of infection there, foreign body, and sometimes post-sequelae bronchial strictures occur. Saccular bronchiectasis, varicose bronchiectasis, amenable to surgery, localized. We should start thinking about surgery in these patients. While cylindric bronchiectasis, as mentioned earlier, perfusion is retained in the area of cylindric changes, and this type, therefore, is not a primary indication for surgical resection. So important to know and learn from the HRCT that saccular and varicose we need to identify and separate it from cylindric bronchiectasis. And then comes this very fancy term, pseudobronchiectasis. This happens in patients who have infection and the bronchi are become dilated, mimicking bronchiectasis at the time of the infection, and the HRCT would throw up this diagnosis. However, with the passing of infection, they come back to normal size, so hence termed pseudobronchiectasis. This was just to show you when one of the causes for bronchiectasis could be a long-standing foreign body in the main bronchus or in the lobar bronchus. And this was there in the patient for about 5 years. We removed this, but however, we had to subsequently go in for a lobectomy. Then how do we diagnose it? Clinically, you have low cough, hemoptysis, as we've discussed, and important tools, the long list, but what is most practically we use is fiber optic bronchoscopy, and this is a must. Even if you have HRCT reports, you should go in and scope them. Why? For two reasons, just to make sure there is no stricture, there is no obstruction, and secondly, most importantly, to have a bronchial toilet and get directly the organism to possibly target the organism which is being harbored. Bronchogram, we grew up in the age of bronchograms. We didn't have CT scans. I'm talking way back in late 1980s in India and early 1990s. CT was just coming in. So we were trained to do bronchograms, and that helped me. Not only did I identify the disease, but subsequently to use this simple procedure in the ICU for nasotracheal suctions. You don't need a bronchoscope, and it's a blind procedure, but most useful. And of course, HRCT, and then PFT, pulmonary function test, sounds very basic to us. Leave it to the pulmonologist, but we need to know certain important criteria in that. And we need to finally, why? Because we are the ones who are going to put the knife on the patient. So we should have fairly a good idea about PFTs. And then of course, if ideally, ventilation perfusion scans are a great help for two reasons. One is for preoperative assessment, and thereafter for post-operative two, this helps in deciding on which patient would be safe after surgery. This is just to show you a bronchogram is more of a historical museum kind of piece now. And we used to use a diagnosal dye, and usually done in the afternoon. The patient doesn't have lunch, and we go into the radiology department under screening fluoroscopy. This is performed, and this is how a normal lung would look like. Followed by, you see this ectatic quality of the pictures are the best I could get, something I dug up from my past, from the archives, from my archives. So this is where you can see the difference as opposed to this is quite narrow. Here it is quite dilated. And similarly, this bunching, crowding of bronchi. VQ scans, we should read it. And I personally think we all should personally look at it ourselves, VQs, HRCTs, because to err is human. This is a patient who has a perfusion defect. This is the left lower lobe, as you can see in CT. And that is telescoped here, this hypoperfused area. So once you know this, and there is nothing, no hypoperfusion, the rest of the lung, this area, if we can resect, would definitely benefit the patient. HRCT, important for us. Obviously, you can see the cystic bronchiectasis here and some more scattered bronchiectasis in the upper lobe. This is the middle lobe. What we look for is dilatation, which is here, peribronchial inflammation that reflects and gives us a clue how difficult the surgery could be. Lack of tapering within 1 centimeter of pleura. This goes right up to the pleura here. Mucus filling, where you can see mucoid blocks here. Central lobular nodules make surgery a little more difficult, but possible. The branching areas of soft tissue and attenuation, and more importantly, most importantly, very importantly, if there is consolidation, would mean that a lot of secretions which could be organized. This is interesting, and the reason why I've displayed the CT scan is, although the bronchiectasis in this tiny area is what we think, this is the entire lower lobe. And that's what's called as lobar retraction. These patients do extremely well. Why? Because the source is gone and the rest of the lung can easily expand and fill the space. Now, with the improvement of healthcare and the availability of suitable antibiotics, the general prevalence of bronchiectasis has declined. And the patients with early disease can be treated successfully by conservative procedures in the developed world. So there do not, at various meetings, various forums, bronchiectasis is usually considered as a medical treatment. Now, the current literature clearly states that the primary therapeutic goal, I'm talking of current literature, for bronchiectasis patients must be optimal medical treatment. We do not disagree on this point. Appropriate antibiotic therapy, because we saw infection as a major issue. Bronchodilators, you have various bronchodilators which could be used for COPD, as well as once the bronchus dilates, more secretions possibly could come out. You can have mucolytes. And most importantly, very importantly, is physiotherapy. You need a good rehabilitation team, a good physiotherapist, respiratory technicians, postural drainage is prime importance. So this is treatment. This is medical treatment. And now what do we do? In medical treatment, of course, diagnosis through all those various tests we listed. And if there's a cause, identify the cause. I said about 30 to 40 to 50%, or 30 to 40, 20 to 30%, we do not have a cause. But if we do have a cause, go ahead and fix it. Acute exacerbations, treat with antibiotics. Frequent exacerbations may benefit with prolonged and aerosolized antibiotics. May benefit, please note. Role of mucolytes, anti-inflammatory agents are not clear. Touted very much. There is no hard evidence that really makes a difference, but they are touted, and that's what they stand on. Antibiotics, mucolytes, anti-inflammatory agents, aerosolized antibiotics, oh, we have changed the face of bronchiectasis, is what the uh, pharmaceutical world says. And now bring in pneumococcal vaccines. Boy, we have cured it. Have we? There's lack of reliable evidence to support or refute the use of pneumococcal vaccines in bronchiectasis. Another patient has massive hemoptysis, not fit for surgery, or is in the waiting period. Of course, the physician says, oh, we'll go and send him for an interventional procedure, and then we will take care of it. Now, this bronchial arterial embolization therapy, my dear friends, remember, is only a temporary procedure. It's a bridging procedure. Why? Because you may block the uh, parent artery, but collaterals, as you know, is the way nature behaves. Just like a river is blocked, tributaries open up, other channels open up, and this is a systemic vessel, bronchial artery, from where the bleed usually occurs. Now, I had mentioned earlier, if you remember, about antibiotics and Pseudomonas aeruginosa, why it is so dangerous. Studies have shown there's an accelerated there's decline in lung function and causes frequent exacerbations when a patient has repeated Pseudomonas. Further, it has been demonstrated a 50 ml decrease in FEV1 per year in patients who have infective episodes of bronchiectasis. A 50 ml is significant every year. So generally, the vast majority of patients can be managed with conservative treatment. Agree. However, with surgical treatment being reserved for focal disease and medical treatment is no longer effective, surgical treatment for focal lesions do not persist, do not continue with medical management. And that is one area for sure. Now, when medical treatment is no longer effective, that's more than 2 times a year hospitalization, think of surgery. There may not be focal disease, but there could be scattered bronchiectasis. You could make a severe disease to a moderate disease and a moderate disease to a mild disease with surgery if possible. So please explore that. And this has to be passed on. And this message needs to go down with our fellow colleagues, the physicians and the pulmonologists. Now, very few publications world over are available, especially in surgery. Why? I shall come to that in the next slide. But however, these publications are essential because the nuances of technique, methods of assessment, anesthetic management, and the wealth of other information that remains blinded to surgeons should become available. And this is so, especially most publications come from the West. So areas of low incidence, people would stand to benefit. So we need to have more publications. And we are also efforts in India too. Now, bronchiectasis is one topic in which an information disparity exists. Controlled trials proved impracticable, and enthusiastic reports of surgeons were necessarily reviewed with some skepticism. Skeptics, of course, will always we run up against this wall, and skepticism is a stumbling block. Maybe because of the excessive zeal for complete resection of bronchiectasis was criticized on the grounds the patient is left breathless or even a respiratory cripple. So there is substance in these statements. We need to introspect, we need to analyze before deciding on surgery and the type of surgery. So you have the standard textbooks which say surgery remains a controversial issue in the management of bronchiectasis. So says Murray and al. Surgery may have a role in selective cases. Well, what is the concept? The concept behind surgical resection for bronchiectasis is to remove permanently damaged areas of the lung, which will never, where no antibiotic will penetrate. And this microbiological reservoir leads to recurrent infection. We need to get to that source. The source is the issue, remove it. Now, the indications, of course, chronic productive cough, that's symptomatic indications, repeated or significant hemoptysis, lung abscesses, of course, then you're stuck. Empyema, recurrent pulmonary infections, non-diagnostic lung masses. You'll be surprised at the number of cases which mimic malignancy. And then, of course, failure of medical treatment. There's a third aspect, especially in the pediatric age group. Bronchiectasis, severe persistence, affects the body as failure of body growth. Examine this chart. Diagnosis of bronchiectasis is made when patient has symptoms. Of course, medical treatment as always. Uh, and then if medical treatment fails or does not, the patient does not show the necessary response, definitely consider investigate further. And if you find localized cystic varicose bronchiectasis, perfusion scans are in our favor. That is, non-perfused bronchiectasis exists. Check resectability, operability, operation, possible surgery, and it leads to complete cure. Complete cure. This will all remain in medical hands. Preoperative investigations, you guys are very well adept at this. Of course, chest x-ray scans, spirometry, ABG is important because one could have associated COPD. Ventilation perfusion scans, and please, my dear friends, do not ignore the heart, which is your neighbor and very importantly, close friend. As being a cardiothoracic surgeon, having been trained, we need the surgeons, the cardiac surgeons ignore the lungs, the thoracic surgeons have a mutual feeling about it, but we need to be sure this is one area where we can avoid actual death. So do be careful, especially with suspected heart cases, heart diseases, echo, thallium stressing, and in required CAG or CT64 will help us know how the extent of the coronary artery disease. Now, pre-operation preparation, once you decide that you're going to take up the patient for surgery, it's not just going into theater and cutting. We need to do a lot of things. For thoracic surgery, especially in subacute lung disease, we need the help of the pulmonologist, optimize the antibiotics and the airway. We need the help of the physiotherapist and they need to give intensive respiratory physiotherapy. It's very, very mandatory. Of course, microbiology examination of respiratory secretions and appropriate antibiotic prophylaxis. PFT, my dear friends, we should have some basic ideas like forced vital capacity FEV1 is a must for us, and of course to distinguish it between obstructive and restrictive diseases. But FVC, FEV1, we should know in detail because it can help us to gauge, predict the post-operative pulmonary function. This is a very uh, simple calculation by Wernley, very simple. Here he tries to formulate and try to understand what would be the expected loss of function post-surgery. Stresses on vital capacity and FEV1, pre-op function of these two, vital capacity or FEV1, separately are taken. Number of functional segments in the lobe to resected are noted, divided by the total number of segments. And if the vital capacity is about 2 liters and the FEV1 is well above 1 liter, you're in safe area.
Dr. Yusuf, just 1 second. Can whoever has written on the screen, please erase it. Okay, please do not write on the screen while the lecture is going on because we are live. Please do not write on the screen. So whoever just scribbled on the screen, please erase it. Sorry, Dr. Yusuf.
Thank you, Dr. Khan. Now, certain measures can be adopted for preventing bronchopleural fistula. The worst fear of the surgeon is a bronchopleural fistula. I'm sure you all agree. Again, it is important to know the microorganism which is present, adequate antibiotics, and do not be in a hurry to operate because it's a chronic condition. So try to get the maximum optimization benefit, get them symptom-free, especially get them bacteria-free. And of course, techniques, it's a huge area of discussion. Coverage of stump during surgery definitely helps. I believe in it. Many surgeons don't do it, but it definitely helps. There are different ways of doing it: serratus anterior flaps, medius pleura, uh, and a few others. Now, what is the basic logic about the how much would we resect? Surgical resection aimed at minimizing the number of resected segments. This is most important. Do not take what you cannot give. We cannot give normal lung tissue. So let's try to preserve it as much as possible. Now, without compromising the objective of elimination of disease. This is most applicable, not applicable in focal bronchiectasis because you remove that focus, no problem. When the disease is multi-segmental, this is a problem. We need to preserve as much lung as possible, normal lung. Complete resection, of course, prevents recurrence. There's no role of surgery in immunologic or genetic abnormalities. We all agree on that. You are well familiar with all the segments in the body. In the lung, we have, just to recapitulate, 10 segments on the right and 8 segments on the left. What happens in the upper lobe? The anterior segment is here, the anterior segment, apical segment, and posterior segment. You can see on the right side, you have the 3 segments in the upper lobe. Here, they fuse, the apical and posterior fuse on the left side. So theoretically, you have only 2 segments, but pretty large segments, but fused. And similarly, way down, the lingular and medial lobe almost the same, 2 segments each. In the lower lobe, the left side, you have the anterior segment and the medial segment fusing together to form the anterior medial segment. And that forms, then you have 4 lobes. Superior segment, of course, is there. Posterior basal is there. Lateral basal is there. And that probably, they have said, is due to the heart being on the left side. So we have basically 8 segments on the left side, 10 on the right. So what does it say? If we can survive with 8 segments, if the 8 segments are normal, because we do right pneumonectomies. So 8 segments is all that we need for a comfortable life, reasonable life. So we can consider bilateral surgery, bilateral bronchiectasis. On table, what I would suggest is that you can make out bronchiectasis by nodular infiltrates, bumps or knobby subster areas. And in general, because it's an inflammatory disease, the hilar structures are divided according to the most convenient manner determined at surgery. However, preferable to do the divisions of the artery prior to the vein because it will avoid flooding of the lungs. Now, during pulmonary resection, kindly try to avoid excessive bronchial dissection because it could cause a BPF, and peribronchial tissue should be preferred as much as possible. Most importantly, toilet bronchoscopy is performed routinely preoperatively after intubation. Please get your anesthetist to do that. Because of chronic inflammation, pleural adhesion is commonly encountered. Chronic inflammation in thick pleural tissue interferes with the dissection of the lobar hilus. Certain surgeons do mass ligation and division may be resorted to. Another approach which will help is to open the pericardium and deal with intrapericardial vessels. As you can see here, large dilated bronchi. And here this whole lobe is completely, the parenchyma has been replaced by this large cystic areas. There is no tissue for ventilation. So once surgery is done, maybe a thoracotomy or VATS, post-op care becomes very significant. All patients, if they have had thoracotomy, preferable to have epidurals in situ. It could be morphine or bupivacaine, whatever the anesthetist decides. We tend to use diclofenac suppositories, helpful if the kidneys are okay. Fentanyl, very good. Patient control analgesia is useful. And this, my dear friends, to avoid pulmonary embolism, I agree that in India and the developing countries, the numbers are low, but if it happens, will not really regret it because it is fatal. So TVT needs to be addressed by mechanical compression devices, stockings, or LMWH. LMWH we tend to use very little because of fear of oozing and bleeding. Antibiotics are administered for 5 days after surgery at least, or longer if the patient has inflammatory symptoms. Percussive chest physiotherapy, very important. Physiotherapy is a must. And fluid restriction in elderly and pneumonectomy is to be definitely adhered to. Otherwise, one could go into the patients could have heart failure. And patients should begin to ambulate as early as next day. Nasotracheal aspirations and rigid bronchoscopy in patients with atelectasis in the postoperative period sometimes is very useful. The patient says with so much of relief, I can get my breath back. I thought I was dying. I wasn't getting any breath. So removal of secretions is very imperative. And this simple technique of passing a suction catheter through the nose into the trachea, blind procedure, is overdone in 5 minutes. But you need to assure the patient what you're doing, get them into your confidence, and it's a very useful procedure. Various advanced centers have this bronchopulmonary hygiene physical therapy. If you have it, you're blessed. And let's now move on to a little more complex scenarios. We're done with simple bronchiectasis. Now, we mentioned about unilateral scattered bronchiectasis, often said only medical treatment. Has surgery a role in that? Or bronchiectasis bronchitis? A very difficult situation in bronchiectasis bronchitis. The patient has cough and at times will have expectoration. And now we're not sure which is more contributory, bronchitis or the bronchiectasis part. And there is no way of knowing that preoperatively for sure. However, I feel if a patient has a definite bronchiectasis segment, we should go in, if the patient can withstand surgery, take it out. And only in the post-op period will we know if the cough has disappeared or not. And similarly, another challenging area is bronchiectasis with COPD, especially seen in smokers. And then finally, bronchiectasis can present as a bronchopleural fistula. So let's look at the unilateral scattered bronchiectasis, and the literature says limited scope of surgery. It remains a distressing problem, is what they say. And when you look at this X-ray, this is a pre-op X-ray, and this patient has unilateral scattered bronchiectasis. Why do I say so? The seating helps me to say so. And here also, you see the entire mediastinum has shifted to the left side. Patient's recurrent cough with copious purulent sputum, retrosternal pain and wheeze, mimicking asthma. And here the mediastinum is shifted to the left side, and see what the HRCT shows. Right side fairly normal. There's in fact herniation of the lung into the left side. There you have these large cystic areas. And there is definite loss of lung volume. However, surgery does help him because nothing else worked, and these areas were excised. And now look at the post-op X-ray. You'll be startled, surprised, amazed. This is the pre-op X-ray. It looks almost normal. The mediastinum has swung back to its original position. Why has it happened is because the lung has become plastered here. You resect this area, this lung is freed and it expands and fills the space. So at times, surgery can do miracles. And this is another patient, I've not revealed the diagnosis yet, presented with recurrent infection, and finally he had a bronchopleural fistula, mimicked like a lung abscess. But in reality, it was bronchiectatic segment, middle lobe, which got infected and increased in volume and became a bag of pus at various places. We went in because he had presented as a bronchopleural fistula. He had a chest tube in. And as you can see, this is the upper lobe, this is the upper lobe, this is the middle lobe. You see an opening here. And very well seen here. Why do I say it's middle cell? On the right side, you can see the SVC here, the collapsed upper lobe, the middle lobe here, and we see an opening. And what happened next? Interesting. We dissected this area to decide whether we should do a middle lobectomy or close the bronchopleural fistula or whatever. And when it was, while dissection was going on, there was compression, and when we expressed the stuff which came out was this, a long worm-like structure. This, my dear friends, is not a worm. It was the same shape. The pus had taken the shape of the bronchus, the segmental bronchus, the lobar bronchus inside. And this, you can see it just crumbles when we try to remove it. It just comes apart. And once that was removed, the bronchopleural fistula became very obvious. Drown this pleural cavity with fluid, ask our dear friend across the anesthetist to ventilate, and you see very clearly where the bronchopleural fistula was. You have to believe me, but now I'll give you proof that what was it? We did surgery, we did a middle lobectomy, and it showed clearly that the patient had bronchiectasis with abscess formation, which organizing pneumonitis, which ruptured to form the bronchopleural fistula. Bilateral bronchiectasis is another area which is a huge challenge, both for the medical team as well as for the surgical team. He has this X-ray. If you look closely, I do not know whether you can appreciate it, but on both sides there is bronchiectasis confirmed on CT thorax. This is a case with minimal bronchiectasis, right? I would say it minimal. Why? Because he has a, this area, the posterior medial area of the left side, the lingular area, the middle lobe area are affected. But it's bilateral. Classically speaking, bilateral bronchiectasis is not supposed to do surgery. But however, if we take this segments out, there's only the middle lobe here. This middle lobe, and take the ligula here, middle lobe here, ligula here, and that small segment we saw earlier, posteriorly, you have extremely good lung. But the catch here was that he has COPD along with this. But went ahead and operated on one side. We prefer to do the side which is diseased most, but certain people do advocate operating on the side which is diseased less. However, I believe that we should do this disease side more, because at times you'll be surprised that the side on which you have not operated sometimes just responds or becomes symptom-free, and all that you need is medical management. So this is the same patient, which showed the cystic spaces seen completely filling left lower lobe, cystic bronchitis, minimal bronchitism, right middle lobe, and lower lobe. So bilateral thoracotomy in this patient, another patient was done. In fact, this patient, both sides were done. This is an open procedure. And we presented our data in 2007 at the National Conference of the Indian Pulmonologists in Delhi. The National Conference is a joint conference of the National College of Chest Physicians and Indian Chest Society, and this was in 2007. And now look at this X-ray, where the left side has clearly more bronchiectasis. This is again right side. But now when we do it on the left side, you can see there is loss of lung volume, because this is a large area. But fortunately, the rest of, we could preserve the entire upper lobe along on the left side. So at times, even after you remove this, there's a problem of space. But here in this particular place, we didn't have that problem. So who are the candidates for VATS? Thoracotomy is established, but VATS is coming in the early 90s. Young patients with aesthetic demands. Now, the conditions are quite severe. No severe parenchymal or pleural scarring, preferably they should be avoided. And I feel calcified lymph nodes, one should go in for an open procedure near the PA and veins. And if symptoms of purulent sputum have been exceeding 5 years, it should be less than 5 years for, otherwise it means it could be chronic. It's a chronic process. Many of the segments could be infected. And put in the scope first and see the viability by inspection through ports, and if required, convert it to thoracotomy. The advantages of VATS is innumerable. Safe procedure when performed by experienced physicians. Pain is less. Better preservation of pulmonary function in the early postoperative period. Early return to full activities and better quality of life. That's very important. And of course, in older and sick patients, preferable to do VATS. So VATS in localized bronchiectasis is a safe and more efficient procedure in selected patients with better recovery as opposed to a thoracotomy, shorter length of stay in hospitals, fewer complications. But if you're not comfortable with VATS, most important is safety of the patient. And secondly, the result is what matters. Whatever is comfortable, please fully adopt that. Of course, a few disadvantages exist. As I mentioned, calcified lymph nodes, adequacy of parenchymal clearance in multisegmental disease. You do not get a proper clearance of its VATS. Inflammatory changes might render dissection more difficult, especially adhesions to chest wall, the hilum, and fissure. This area, I mean, although people say it's a problem, but I think VATS will help in this area. There's a short video, but uh, there's a. This view shows the. This is okay. That's a short video, but however, it's a classic VATS. But I've been told VATS has already been discussed before, and you have this. These are the small incisions with VATS, and then of course the area where Dr. Khan is an expert, a specialist in this field, robotic surgery. And then you have this little slide which says, if it is a robotic surgery, why should I pay the surgeon's fee? But robotic surgery has come to stay, and the advantages has already been probably discussed in the previous sessions with Dr. Khan. Greater, when you compare VATS and RATS, greater visualization, enhanced dexterity, greater precision. This is something which I'm very impressed with. Hand-eye coordination, restored, ergonomics, fantastic. Relax and do the surgery. Fulcrum effect is eliminated. This is some areas which most robotic surgeons don't talk about. Expensive, they say yes. They find their ways to get around it. Risk of human error is in fixing the machine. Potential for mechanical failure. Arms can fail, cameras can get uh, blurred, or some chips could go. Accidental burn injuries have been reported. But by and large, RATS has come to stay. Now, what are the morbidities for thoracic surgery? What we fear most is a BPF, but we do have prolonged air leak, which usually settles. This is an alveolar leak, which will usually settle within a week. Bleeding, not so commonly seen these days. BPF, God forbid that it happens. Wound incidence, all manageable. And coming to bilateral bronchiectasis, it's technically difficult because the fissures are not developed. Sometimes you have to go through good lung, and there is a chance of persistent leak. It's a prolonged surgery, and the most, what is life-threatening if the opposite side gets flooded and risk of blockage of both airways due to secretions. It's a horrifying situation. Now, when you look at this particular paper, has tried to compare VATS with thoracotomy. I mean, I say they have done a cohort study and they have adjusted variables. The length of stay definitely less with VATS. The cost is more, but importantly, what they have not mentioned is, of course, it's a post-operative period, is they return to work much earlier and the quality of life is better. This was in 86 patients. After surgical treatment, 71 of 86 patients were free of symptoms. Excellent. And the remaining 15 had a reduction in preoperative symptoms. Good. The 53 patients with localized perfusion defects, VQ scans done, underwent complete resection and had symptom-free postoperative results. What more do you need? Cured. Results of surgical bronchiectasis, mortality is very minimal. There are lots of, I mean, few series, and we had about 2.7%, but our morbidity was a little more than some of the papers. And this is a large study which has come out with 487 patients, and they've just shown the distribution, humanectomy being done in a fair number, followed by lobectomy. Now, this is interesting. Lung function after 6 months. Forced vital capacity, not much difference. But FEV1 definitely is better in the post-operative period. Types of resection we discussed. Bilateral surgery, I just shared with our experience, but this is only up to 2007. We had bilateral surgeries, unilateral surgery, 66, 46. Single sitting in 8 patients. We were very adventurous then. Bilateral median sternotomy you can do, middle lobectomy and lingulectomy through a partial medial sternotomy. You don't have to open the whole thing. A lower down sternotomy is sufficient. Bilateral thoracotomy in one. List of complications long, but I have to list it as a to make the talk complete. What is of importance is prolonged airly expansion failure. This is a very important area, not much discussed. This happens when even you might do only a lobectomy, but that space, especially in COPD patients, is so much the rest of the lung doesn't fill it. Or you remove, you only leave 3 segments behind. Again, it's a challenge. These are the comorbidities one would face with age, renal failure in patients, obesity, a challenge, but VATS overcomes this problem. Hypertension, coronary artery disease needs to be looked out for. Of course, diabetes and wound healing and infections could be a problem. COPD requiring non-invasive ventilation at times, and age, of course. But age today is no bar with VATS having come in. So FE1, these are the predictive post-operative complications. FEV1 of less than 60% of predicted value. FEV1 less than 60% expect problems. Incomplete resection in scattered bronchiectasis, there could be problems post-op. And preoperative antibiotic was very essential. Isolate the organism, and then you're in business. Relapse occurs. And when do they occur? Again, as I reiterate, Pseudomonas aeruginosa is a huge culprit. Residual bronchiectasis after okay. Preoperative extent of bronchiectasis also is a factor. Immunocompromised status, that group is always a challenge. Diabetes, cytotoxic patients on chemotherapy or on immunosuppressants. Complete resection is possible in various, I've taken various studies and they found complete resection in 58%, incomplete in 42%. All had alleviation of symptoms, note, including this. Relapse, 14%, that is hemoptysis and lower respiratory tract infection. So relapse is possible, again, unilateral scattered bronchiectasis, pre-op extent of bronchiectasis, and predicted post-operative FE1 have collinear relationship with P. aeruginosa. P. aeruginosa keeps coming up all the time. It's a deadly bug. Patients with perfusion scans depicting localized perfusion defects have a lower complication rate. So how important are these VQ scans? A higher complete resection rate and an excellent post-operative result. Hypoperfused area is thumbs up. Perfusion scan may be used to select patients for operation and may predict post-operative results. All the patients with, outcome, all the patients with hemoptysis were asymptomatic during the follow-up period. The Fletcher dyspnea score, that's important, ranges between 1 to 5. The Fletcher dyspnea score comes down from 5 to 3, 3 to 2. There's a definite improvement. Post-operative FEV1 values were higher than pre-operative FEV1, no difference in FVC. And those with localized perfusion defects in VQ scans underwent complete resection and became symptom-free cured. Let's take a pause here and just look back at what the medical team says. The use of antibiotics in almost every recurrence of pulmonary infections increases the costs of treatment and frequently causes side effects related with these drugs. Hospitalization during pulmonary infections also cause loss of workforce, time. After every acute infection, surrounding normal pulmonary tissues are also affected. It's a progressive disease. So remember that. We mentioned earlier, 50 ml is lost per year of tidal volume, and bronchiectatic areas get larger and larger and lead ultimately to destroyed lung. And the person who suffers and the victim is the patient, socially deprived, socially discarded. Disclaimer here, what I've expressed, what I've shared with you are entirely certain, so most of it from literature and certain my own personal opinions. And this could probably create some controversy, but it is with no intention to hurt the sentiments of my fellow academicians, especially in the field of pulmonology. However, I need to make this statement, especially for surgeons as well as for the future surgeons. Surgery is just not going and cutting up a patient. We need to do more. We need to work as a team, and extends beyond. We have an obligation to society. We need to spread the word, and we need that word to reach our dear friends in pulmonology. So as surgeons, it is our duty to update our pulmonology and family physician colleagues so that patients are counseled at an earlier stage when minimum pulmonary resection will be both adequate and optimal. So statements would be up to 10 disease segments, provided the other 8 are normal. Surgery could be done either unilaterally, a pneumonectomy, or bilaterally. And gray area, 3 segments are healthy, preserve lung and avoid life-threatening and disabling pneumonectomy. I feel that's entirely a philosophical area. Judgments can be made on table. Is the lung expanding after and filling up the space? Or you take the chance and let it's okay, the diaphragm might move up. I've started thinking lately, why not knock off the phrenic? Although they say 80% of respiration, is, my colleagues in pulmonology and physiology say 80% is due to the diaphragm. But which is a greater problem, the unilateral diaphragmatic palsy or an expansional failure, airspace problem? And this third point, which is often forgotten, is the catch-up growth. It's incredible when you operate on pediatric children or 18, 14 years, they look like 10 or 12 years old. 18-year-olds looking like 12 years, and suddenly there's a catch-up growth. Was observed who were operated on for failure of body growth. Basically, please remember, do not take what you cannot give. And let's say what the judgment is and what the judge says after having heard all the evidence. It says, in properly selected patients with or without bilateral involvement, pulmonary resection can be done with acceptable mortality and mortality rates and can lead to lasting symptomatic improvements. Complete resection, complete cure. I love my lung, let it breathe. We should have some humor in life. Surgeons are very stressed, especially thoracic surgeons, and blessed are those who can laugh at themselves, but they shall never cease to be amused. When I talk, I am only repeating what I already know. But when I listen, I may learn something new. So thank you so much, ladies and gentlemen, and thank you so much, Dr. Khan, and I'm willing to listen.
Oh, thank you very much, Dr. Yusuf, for an excellent lecture. This was really an A1 presentation. I'll let you finish your last slide. It's very, very important.
Yeah, this is, my dear friends, we're all humans, and we can cure sometimes and relieve often. Be humble, but always comfort. That we can do at no price. Thank you.
Okay. Thanks, Dr. Yusuf. That was just such a brilliant talk. I mean, what a balanced view you gave of, a very, very difficult subject, actually. Can I ask you to stop sharing your screen so that we can then get you into the, we can get you on the main screen. I'll stop it on this end, okay? So let's get you back in there. Okay, Dr. Yusuf, are you okay to take some questions in terms of time?
Yeah, I'm open to questions with my limited knowledge. I'll try to have a few discussions and learn something from the audience too.
Excellent. So first of all, I'll start off by thanking you for such a brilliant presentation. In the course of your presentation, you showed us some brilliant X-rays of a bronchogram. Now, not many people, the youngsters, would have ever seen a bronchogram. So could you just enlighten them on how is it done and How could you diagnose a bronchiectasis on the basis of a bronchogram?
Can I go back to my slide,
Yeah,
please?
please do. You'll have to share your screen again.
Yeah. Dr. Khan, those who have done bronchograms would definitely say it's not a pleasant experience for the patient. And it's quite frustrating for the surgeon too, or the operator, let me put it that way.
You've got your slides back on. So just go back to the slide of the bronchogram. I'm pretty certain the youngsters have never seen a bronchogram. So it'll be good to just enlighten them.
Yes, here we are. Yeah. Well, once we suspect, bronchiectasis on X-ray in those days, we would normally take the patient up for a bronchoscopy, a therapeutic bronchoscopy, and try to get maximum clearance. The patient is kept fasting, and normally at least for 8 hours of fasting, and brought in because we don't want him to have a vomiting episode and aspiration. What is done is we take a 14 size nasotracheal catheter. It is it's not the normal suction catheter. It is rounded at the tip, and that is what do you call that? What's the name? Anyway, it's rounded at the tip. The name escapes my mind, and we introduce it through the nose and down through the trachea. Now, how do we know we are in the trachea? Before that, we give an anesthetic, local anesthetic of say 4%, and at times we go and give 10%. Although there's again the anesthetic and us, anesthetist and us do not agree, but we because surgeons are bold, so sometimes there's not enough proper anesthesia in the oral cavity, we give 10%, and that too in the form of nebulization. Pass the catheter through the nose, and then the patient will start coughing. Although the cough reflex is suppressed, and we pass it down, and once it enters the trachea, he'll start coughing again. However much we anesthetize the trachea, the bronchial tree. And how do we know the coughing was spasmodic? And ask him to say his name. And then you know he's lost his voice. And then under fluoroscopy, this is done. We advance it under fluoroscopy into the right side. Normally it goes into the right side easily, unless the tracheobronchial tree is distorted. It passes down to the right side, and then is injected. Dye used then was Dinosil. Dinosil was an expensive dye from Glaxo, and it used to cost, I'm talking of about 20 years back, around 2,000 rupees then. So very expensive, and you had to come all the way from abroad. And then you pass the dye through the tube and take it in the supine position, change positions to the lateral position, and head down, head up, trying to fill all the bronchi. So it's a pretty difficult procedure. Then you come back under fluoroscopy, the main bronchus, and by trial and error, turn the patient to the left side, and hopefully it'll go down to the left side. And again, this exercise is repeated. Despite it takes at least about half an hour for the whole thing, and imagine something sticking down your trachea for about 15 minutes. It's so uncomfortable for the patient. And after that, sometimes you don't have enough information. Then you have to repeat the procedure. But CT scan, believe me, when it first came in, as always, we resist change. The surgeon said, no, it's not any good. Radiologist kept telling us how brilliant it was. And it took us a year or two to accept CT. And I'm so thankful that surgeons finally accepted it.
Oh, excellent. It's very good to know the history of the progress of thoracic surgery. It's a very, very fascinating topic. Now, in the course of your conversation, in the course of your lecture, you mentioned that we have four types of bronchiectasis: saccular, varicocele, cylindrical, and pseudobronchiectasis. So my first question is, what is the difference between true bronchiectasis and pseudobronchiectasis? What do you mean by that?
Very good question, Dr. Khan. I was fascinated by this term initially when I read it. And then what happens in bronchiectasis, if you remember the definition, we say it's a permanent dilatation.
Mhm.
Permanent dilatation, no matter what you do, no matter you give inhaled corticosteroids, give anti-inflammatory medicines, give antibiotics, they are going to remain the same size. How even after you remove all the secretions, the patient becomes dry. But in pseudobronchiectasis, what happens initially, the bronchi become dilated, and with antibiotics, anti-inflammatories, they come back to their original size. So it's a temporary state where the bronchus gets dilated. So once you have a uh, pre-procedure or pre-therapy CT scan compared with the post-CT, once the symptoms have subsided, then you'll be surprised to see, happy to see that the bronchiectasis or the dilated bronchi have vanished.
Oh, I see. Okay. And again, for the young surgeons on the group, what is the difference between bronchiectasis and emphysema? Is it two separate things, or are they same, or what is the relation between the two?
Excellent question. This I'm sure if there are any pulmonologists in the group, if they would be adept at answering. But however, in COPD and I mean, your question was bronchitis, correct?
Yeah.
Bronchitis and COPD, correct?
Yeah.
Yeah. The, one is a chronic obstructive. It's an obstructive pulmonary disease. That's an obstruction. There's hyperinflation of the alveoli, hyperinflation of the parenchyma, which causes a kind of obstruction. While in bronchitis, there is inflammation. That's the reason in bronchiectasis and bronchitis, it's very difficult when both exist to say which is a more contributory component. In bronchitis, then there's inflammation, and that causes narrowing and the symptoms and the cough. While in COPD, one doesn't have much cough, if you remember. So that basically lies the difference. There's a alveoli get distended, hyperinflated lung, as opposed to bronchitis, which may be more of an infective pathology and infection and parenchymal crowding, consolidation happening.
Okay. Now the next question is, when you go in to operate, what is the role of segmentectomy for bronchiectasis? Anatomical and non-anatomical segmentectomy. Is there a role for that, or should you ideally do a lobectomy?
Excellent question, Dr. Khan. I think it is dependent on the surgeon, the operator. Each one has his own take. Now, ideally, as you said, if you do a lobectomy, your surgery is complete. One. Second, chances of early are less. But, however, in a patient who has got a compromised lung function, doing lobectomy, we could have a patient who was walking become a respiratory cripple. Then comes a question of segmentectomy. And as you said, anatomical segmentectomy, perfect if you could do it. But at times, most times, anatomical segmentectomy doesn't work because these things are all bronchi kind of, they cross, as you know, the fissure that gets fused. So there is collateral ventilation. So anatomical segmentectomy, if possible, very clearly defined, brilliant. But often we need to go through uh, lung tissue as well. Now the question is then again, it all depends on the function, the pulmonary function of the patient, his respiratory status to decide how much lung we can, how many segments we can go take out. Do we leave anything behind? Most importantly, as I said, safety first and then the result. Leave, better to have a dead patient who is alive. I mean, better not to have a dead patient, rather to have a live patient with minimal symptoms. A dead patient with a complete surgery is probably of no use.
Now, one of the problems with bronchiectasis is that there is a lot of inflammation in the bronchovascular segments, and it's not an easy surgery by any means. Dissection, the perivascular planes are lost. So you mentioned something about mass ligation in your lecture. So is there any role of doing mass ligation, or can you safely take a bronchus and an artery together? Or is there a risk of a fistula formation and things like that? Could you just enlighten us?
Good question. I mean, you're stuck. You're gone in. You're stuck. You can't come out without doing something for the patient. So it's a
Mm-hmm.
desperate circumstances require desperate measures.
Mm-hmm.
And this is a described procedure. Certain surgeons do it. And I too have done it. The fear of a leak, a bronchial stump rupture is quite high, but I've not seen it, to be honest with you, that very often. It does work. Ligation, but I would ligate as well as suture over it. I wouldn't just leave it as ligation because ligation, I think, causes more uh, damage in the sense that you have a risk of BPF being very high. And what is your opinion, Dr. Khan? You've been hearing me. I'd like to hear your opinion and the
Uh,
opinion of the audience. Yeah, let's hear it.
Personally, I have been in these situations which you described, where it was almost impossible to dissect between the bronchus and the artery. Before coming to India, in the UK, when I was practicing, I would always conscientiously dissect between them and take each structure separately. But since coming back to India and doing a lot of TB surgery and doing bronchiectatic surgery, I have actually, and most of these I do by VATS, I have actually clamped and ligated, stapled bronchial artery and bronchus together because it was not safe to dissect between the two because there was a risk of bleed. And I think I must have done about 16 or 17 patients and I followed them up because theoretically there's this risk of bleed or a fistula forming. And so far, I have not come across anybody who has had a fistula. And every time I go to a big meeting, and when we have the Mahagurus, like Rajan Santosham or Dr. Babatosh Biswas present, I always ask them these questions. And they also say that actually it's not, they have not come across a fistula, forming between the vessel and the bronchus. So I think it is okay to do it in the situation. And I like the fact that you said the patient must be alive. That's the most important thing. So yes, I completely agree with you on that. Now, if you have to operate on two sides, okay, you said you always prefer to operate on the side that is worse, and then do the other side later, or sometimes the other side improves. So have you done bilateral surgeries in these group of patients, or do you always do it one side first? And if you do it one side first, what is the gap between two surgeries that you would keep?
So I think I showed my figures once again to
Hmm.
recapitulate. We have done bilateral surgeries in the same sitting, right? That is specific cases where the middle lobe and the lingula are the disease segments. So you will be surprised. You can do a lower sternotomy and access the two sides without a problem. Otherwise, once we did very boldly, very bravely, very courageously early in my practice, uh, in the same sitting, did one side a lobectomy, which was quick, and we said, hey, why not we take the other side, which is a segmented. But thereafter, I have always done at two separate sittings, and the gap to be decided usually 3 months, but that's not fixed because we need to convince the patient. Once we do the worst side, the problem is you do the worst side, the patient might become asymptomatic. So so we need to wait. And many patients don't agree to after surgery after 3 months. They said, "Can we wait?" Of course, you can wait. And we follow it up with CT scans. And some of them don't need surgeries. There could be bronchiectasis, but not causing any symptoms. So there's no hard and fast rule as to when. Okay, now 3 months up, I'm going to do it. If the patient becomes symptomatic, has hemoptysis, continuing hemoptysis, or recurrent infections, then go in. But if he's asymptomatic, I would wait. And then let the patient earn his surgery, is what I believe. Tell them the facts, give them, lay it bare on paper, and it's up to family and the patient to decide. We have had patients also coming in after seeing the success of the first surgery, especially in children, especially in girls who are waiting to get married to come and get it done, or soon after marriage for a impending pregnancy.
So just to reiterate the message to the youngsters, actually, bilateral surgery is not a good concept in thoracic surgery because patients don't do well with pain on both sides of the chest. You know, thoracotomy or even VATS is not well tolerated because of the pain. And the whole mechanics of respiration changes in a big way. So as far as possible, you should try and avoid bilateral surgery. If you have to do bilateral, then access it either through a median sternotomy and then get into the right and left side, or do a subxiphoid incision, and then
Correct.
your camera can go into the right and your camera can go into the left. But to do two thoracotomies or two VATS procedures on the two sides is not a recommended modality. And almost all of us have done it in the past and have regretted it. That's the reality, because unfortunately the price is paid for by the patient, and they struggle, and that's the truth. Now, my next question to you, Dr. Yusuf, is these surgeries have to be carefully planned. So, what is the role of preoperative rehabilitation for these patients? You know, in the UK we do minimum 6 weeks preoperative rehabilitation. So, what's your practice? Do you recommend that? Do you think it's a good idea to do that?
I'm in total agreement, Dr. Khan. However, in India, it doesn't work out in many cases. So we need to get around it at times. But if possible, the pulmonologist and the rehabilitation team, we all sit together and decide once a patient is coming in for surgery, that would be the ideal situation. No two opinions about it.
Okay, and when you are in there doing the surgery, the lung is collapsed. So how do you decide that your extent of resection is adequate?
Disease segments certainly have to come out. Gray areas, what happens is, you need, this all goes through experience, and you develop your own protocol, is that we ventilate, see how much of FiO2 is required for ventilation, getting saturations, how long does it the lung take to bounce back.
Sure.
So all various criteria go in, and this is a very interesting area of discussion, which could take a long time. So everyone, I'm sure, develops their own ways of deciding, yes, this is enough, I'm not going to go further. Another important thing, as I mentioned earlier, is expansion failure. Now, we remove a certain amount of lung, and we think the disease is still left behind. We are concerned if we remove too much of lung tissue. I'm not talking of normal lung tissue, because then what happens, say, ideal situation, a classical example is to leave the tri-segment on the left side alone. Many people say that's going to cause a huge space problem. The lung may not expand and fill the pleural space. And then you're stuck with it. You have a post-operative, invariably the pulmonologist, all of them come rushing and say, so there's a pneumothorax. There's a hydropneumothorax. But that's not truly a pathological stage. It is a stage because the diaphragm is not moving up, mediastinum is not shifting, it's a fixed mediastinum, and you're stuck with this. And what do you do in such situations? Well, I'm just saying this is my experience. What I would do is, yes, the lung may not expand. Yes, there could be a space. Yes, there could be fluid. But if it's causing no symptoms, not causing any harm, leave it alone. Don't try to even thoracosynthesis. You could introduce infection. Where do you get this idea from? A post-pneumonictic space.
Sure.
Post-pneumonictic space, you have a space, you have fluid there, you have a so-called air fluid level, and we leave them alone. So this is possible, but they can get into trouble because pathology here is you remove lung, there could be infection. The rest of the parenchyma might have infection. It could be incomplete resection. So the pleural space may get infected. That's a counter argument. Well, you have to play it by ear, take it case by case, and proceed.
So the message was treat the patient, not the X-ray. And in answer to this question to the youngster who raised it, is that whenever I am trying to do a surgery like this, if I have to staple on the lung, my philosophy is the stapler has to go on normal lung. That's the bottom line. So the extent of resection is decided by where you find normal lung. That's the trick. And if you feel that you are not able to staple on normal lung, it's safer to do a lobectomy than to do a segmentectomy. Because if you leave behind staple line on an abnormal lung or a bronchiectatic lung, you are going to run into trouble in the post-operative period. So you really need to work out very clearly, what is the diseased area and what is normal lung. And that comes with experience. Once you keep looking at a few, you will realize where is normal lung. But preoperative CT evaluation is extremely important. It gives you a good idea what should be the level of your resection. Dr. Yusuf, there's a question saying, what is the role of lung transplant in a case of bronchiectasis?
Yeah, I can, just before that, I can see two names, Dr. Mahesh Jansari, Dr. Nikhil Salandar, all pulmonologists. Wonderful to have you guys on board. Very nice. And they are both, Nikhil is from Mumbai, senior man. And earlier I saw Dr. Narayan Mishra on the line, his photograph. He was a past president of the Indian Chess Society. Oh, we have got very eminent luminaries here this evening. Lung transplant is useful in, say, cystic fibrosis in those areas where it is congenital problem, not in these post-infective patients, which you could see. Bilateral bronchiectasis, nothing works, end stage, you have no option but lung transplant. So one of the indications for lung transplant is bilateral bronchiectasis, extensive, not amenable to medical treatment, and where surgery cannot salvage the patient.
Dr. Nanesh wanted to ask a question. He is a senior cardiothoracic surgeon, predominantly doing lung transplantation. Dr. Nanesh, you raised your hand. Are you still with us? Okay, he's probably left the room. I'm very happy for Professor Mishra to give us some input on bronchiectasis if he's still with us. Okay, let's get on to the next question. At what peer pressure and beyond would you avoid surgical management?
Excellent question. I was reading that question. Again, to be on the safe side, pulmonary artery hypertension is a huge problem. We as surgeons probably tend to take it not so seriously, but anything I would say is, they say, mild to moderate, severe, and going above 60 being severe, but 40 and above, be careful. 40 and above is I don't want to be bitten. Once bitten, twice shy, Dr. Khan. Better to have a live patient than a complicated or patient going on ventilator. And the catheter I was trying to recollect for this nasotracheal suction, as I said, the end of the catheter is round, not the usual suction catheters. If you recall, the suction catheters which are normally used for suction it's cut at the end, it's straight cut. So that can cause a lot of trauma if you use it in the bronchus. So this is a rounded tip and is known as Nelcat, freely available in the ICUs. And the standard Nelcat we use is 14. And this is a very useful procedure for post-operative nasotracheal clearance and bronchial toilet of aspiration.
I think Dr. Nanesh is back with us. Dr. Nanesh, you raised your hand. Did you want to make a comment on bronchiectasis and lung transplantation?
Yeah, can you hear me?
Yes, we can, sir.
The guidelines say that if we have 3 infections with diffuse bilateral bronchiectasis, then these patients would benefit by lung transplantation, requiring IV antibiotics. And if you have 3 or more admissions, then this would be. What would Dr. Yusuf's comments be?
No, I quite agree with you, Dr. Nanesh. Absolutely. Absolutely. Then we have no choice, have we? This is the only alternate, not alternate, this is the only recourse.
So in terms of surgery for lung transplantation, when you operate, what is the difference between doing a lung transplantation for a cystic fibrosis as opposed to a bronchiectatic patient? Is it any different, or is it all equally difficult, or equally
both
straightforward?
are equally difficult? Yeah, no, both are equally difficult in the sense that you have to cover them with antibiotics preoperatively. You have to clean once the pneumonectomy is done, you wash the endotracheal tube with betadine solution, which we collect in the thoracic cavity and in a cup, and then we ask the anesthesiologist to flush that twice. If the patient has got pulmonary hypertension in association with it, then of course it's even more complicated.
Do you do single lung transplant in a unilateral bronchiectasis?
No. It's mandatory to do. It's one of our indication for mandatory double lung transplantation.
Sure. And have you been in a situation where you've done a heart lung in this group of patients?
No, we have never done. I have not done a heart lung for bronchiectasis. But of course, if the patient has got severe pulmonary hypertension along with bronchiectasis, and if the right ventricle is beginning to fail and is requiring inotropic support, then that would be an indication for heart lung transplant. Otherwise, most of the time, the right ventricle will recover with double lung transplant.
Okay. Thank you very much for that. Dr. Yusuf, they're asking you, what is the minimum FEV1 below which we should avoid a lobectomy?
Oh, good question. Good question. I can tell you what the recommendations say, but in practice, I don't follow it entirely. Ideally, for a lobectomy, you should have an FEV1 of at least 1.5, and for a pneumonectomy, 2 liters. But we have done in patients with 1.2. Why? I am not a great fan of PFDs. I'm not a great fan of PFDs in the sense that patient compliance, patient compliance is sometimes difficult.
Sure.
So we can't depend it. So I go and buy the 6-minute walk test and climbing of floors. Sounds very basic, sounds very crude, sounds barbaric. But those are the guidelines I would more depend upon. Of course, do a PFT, has to be non-mandatory for legal purposes, but look at the actual exercise tolerance. And then you take a call on that.
Yeah. We did a long talk on this, and bottom line is, I think the best guidelines, if you look around, is the ESTS guidelines for fitness for surgery. So FEV1 as an isolated value is actually no longer an acceptable concept. You have to do there is a whole sequence of tests that you need to do before you can accept a guy for surgery. So what about ERAS? They're asking you about ERAS. Are you going to show some slides? Were you going to show?
No, I'm fine.
Okay. So what about ERAS? Tell us a little bit about ERAS in these patients. You do early recovery after surgery,
enhanced recovery after
surgery.
Hey, that's a question most surgeons are not aware of, or even Dr. Khan. But fortunate from on my part, because I found it very interesting. ERAS guidelines came early in 2019, and especially for thoracic surgery. I think that is a discussion. I'll put up a few points on that, and I think you should have a discussion sometime on ERAS, especially with thoracic surgery. ERAS is a very early recovery after surgery. It's a very good concept. They have analyzed the various postoperative risk factors and what they have, and then reached certain conclusions. And I will just not further take the stock, because there is one statement which I totally was perplexed in ERAS. What they said was you can take out your chest drains with even if it's 300 ml. Well, I don't know what your take is on that. I wouldn't do it. I would wait for at least 100 ml. This is 300 ml. You can take your drains out, and that was my impression. And I didn't make any further comments about ERAS. But on the whole, it's a very good. Every surgeon, every pulmonologist should read about it. Very good takeaways on post-op care, avoiding various complications, and minimizing stay in the ICU, minimizing stay in the early ambulations, which I quite agree with. But this caught my attention. I said, oh my God. Your take, Dr. Khan?
Well, Apar Jindal, who asked this question, may I refer you back to our YouTube channel, Thoracic Gurus, and you will see I've done a 2-hour lecture on ERAS. So this is a topic that has been extensively and deeply discussed.
That's great.
And in response to Dr. Yusuf's comment about whether 300 ml should you take the drain out, I am completely opposite. I am actually very dramatic. We have read the papers of the Copenhagen group, who have published a series of 700 plus cases where the amount of fluid made no difference to taking the drain out. In fact, some patients were, the drain came out even at 500 plus ml, and the number of drains that went back in was less than 1%. So in our clinical practice, no longer the amount of fluid is an issue. We just take the drain out next morning. We connect the drain to a digital suction device. Next morning on the ward round, once the lung is expanded, there is no air leak, and chest X-ray confirms that the lung is expanded, the drain comes out. So it's all individual practice, I suppose. You kind of it takes time to get used to this. When I trained, I was also taught about this 100 ml cutoff, but I no longer practice that. Over the years, you get a bit bolder and bolder, and then when you find that you don't need to put a chest drain back, then you don't worry about it. Because there is also this textbook of tubeless vats where Zhanje He from Guangzhou has published again a series of 700 plus cases where he has used no chest tubes post lobectomy. So there is, I think things are changing quite dramatically, and we've got to be receptive to the change.
Could I just interrupt your
Yeah, sure.
Dr. Khan? I'd like your opinion. In patients with infective pathology, where we do
not in infective pathology.
Exactly.
You don't do that in infective
right.
pathology.
When
This
we
is
do like
routine lobectomy post lung cancer.
Exactly.
Not in infective. In infective, you stay longer. You stay till you're happy that the fluid is clear and bug free. So not in infective pathology. You're absolutely right.
It's great to have Apar here with us. He's the face of lung transplant, up and young, upcoming pulmonologist. He does tremendous work based in Chennai. If he has any comments, it's always nice to hear from him.
Apar, would you like to comment on this? I am a great proponent of ERAS, so thank you for bringing it up.
Thank you, Dr. Yusuf, and that was a great talk, brilliantly put, and as always, very elegant. Your style, just dot the information, your style as well. Thank you so much for that. So I was very happy that both the concepts that Professor Lord, the lung transplantation for bronchiectasis and ERAS came up and they were discussed. So just echo your thoughts over there. We've been doing that, getting the drains out earlier, not following the 100 ml cutoff. And as you've said, at 300, at 350 mLs also, we've taken out drains, and these are like post-transplant patients as well. And these patients do tend to do well. So I don't think that, keeping the drain longer helps them in any ways. And then when it comes to transplant for the bronchiectasis, again, agree with all the facts that have been put in. Bilateral bronchiectasis is the rule. Heart lung only and only when you have a combined heart and lung failure. You need to document that the right ventricle and the left ventricle are also in trouble and will not remodel or recover post-transplantation. So again, thanks a lot to you guys for organizing this beautiful webinar.
Excellent. Thank you, Dr. Apar. Dr. Rajkumar Yadav is one of our senior cardiothoracic surgeons from Jaipur, and he's asking you, how did you do and what was the result of the middle lobectomy with abscess, BP, fistula, and empyema? Yeah, that was a very interesting case.
Yeah, thank you so much. That was a patient, his name is Bipin. We had done only about 2 weeks back. He was discharged 2 weeks back. Youngster, 32-year-old man. He works for the press, dangerous people. Came in with heavy recommendations. He presented as a case of bronchopleural fistula, not to us, to another hospital where they do exactly heart transplants in the city of Cochin. So he presented to them as a bronchopleural fistula, and thereafter they put in a chest tube. The lung wouldn't expand, bumping away to Clory. In the meantime, the pulmonologist there, looking at the X-ray, was concerned, and he thought that condition of the patient kept deteriorating, put him on steroids. He was under the impression it could be ABPA, and he was on high dose of steroids of about 40 milligrams when he was referred to us, and he was in a pretty bad state. But however, his CT scan did show bronchiectasis as well, and we had this BPF. So we went in and told them this condition was, quite critical. We said that we would try to save the life first, and thereafter think of doing two surgeries. So we were planning to do is close the BPF and see how it goes. Went in, the middle lobe was badly stuck at the hilum, the mediastinum. We had to, in fact, we get, once surgeons go in, we get more and more brave going and don't feel like closing and coming off. We knew, and the BPF was arising from the middle lobe. So if we took out the middle lobe, it would be a cure for his bronchiectasis as well, because he had a cough for the last 15 years. He could not sleep at night. His wife had to sleep in the other room. It was so quite bad. So finally we decided we would do that. And it took about 6 or 7 hours. And we did an open procedure, not a wax. And we had to open the pericardium and then finally managed to get the middle lobectomy out. And believe you me, he did extremely well and was discharged on the 8th day. He said a 2-in-1 job, doctor. He has forgotten how to cough now, and his tubes are gone.
Excellent. Excellent. So another good question which has come across is tuberculosis and bronchiectasis, and especially MDR-TB in bronchiectasis. What's your take on that?
In fact, last year a paper of mine came on this topic, and so it's quite close and dear to my heart. As you know, very few centers are doing surgeries on MDR-TB for various reasons. One is technically very challenging. Second, hospitals are not very keen because if you expose the whole team to this, the theater has to have certain requirements, and this can only be done on the weekend. So generally, hospitals are not very comfortable for us to do it. But my take on MDR-TB is multi-drug resistant tuberculosis is, despite treatment of say 2 years, that's a maximum. I mean, we wait 2 years and the patient continues to have EFP persistently positive drug resistant tuberculosis, but with a focal lesion, a localized focal lesion, maybe due to bronchiectasis, maybe a cavity, or maybe due to an abscess. Go in, and I have never regretted it. Go in and take it out.
Okay, and what about pediatric bronchiectasis?
Pediatric bronchiectasis, and I'll come back to it, MDR-TB. Mostly we have found within 2 weeks the patient's sputum is AFP negative, but we continue treatment for 6 months to 1 year, depending on the type of bacteria grown and how the sensitivity is. So most of them convert within 2 weeks. Coming back to pediatric bronchiectasis, my experience, I love to do pediatrics, and I think thoracic surgeons should not leave it to the pediatric surgeons to do it, because we have a better idea, understanding of the lung. We do only lung. I believe the cardiac and vascular part of it, day in and day out. We sleep lung, we wake up lung, we breathe lung all the time. I love my lungs, and I wanted to breathe. Similarly, we are the most adept and competent people. The problem comes in, I do pediatric cases, and that too, don't get many referrals, but it does come in because, as I told you, we have to reach out to the pulmonologists, ENT surgeons, pediatricians, and tell them what we do. Then they start referring patients. And coming back to the point of pediatric bronchiectasis, not many cases, but many other pediatric cases we do in the thoracic part. But however, it's a post-pneumonic, there is post-infective. You'll be surprised. Most of them will cure and will vanish within 6 months to a year. Often I had thought that they would need surgery subsequently. They don't. But if it persists, definitely you can take it out. If the family and the pediatrician agree to it, results are excellent.
Yeah, I just want to share my experience with pediatrics. Fortunately, I've had a huge referral for pediatric bronchiectatic surgery In fact, I have a big series, and out of which I've operated on 6 patients in a single family with Carter-Jean's syndrome who present with, bronchiectasis segments. And the outcomes are excellent, actually. You really, you take away, these guys are suffering for years, 2, 3, 4 years. They are having recurrent chest infections. They are repeatedly in hospitals with IV antibiotics, etc. And then you go in and you take away the offending area. And these guys get back to pretty normal lives. Though we always explain to them that there is a chance that the bronchiectasis could progress on the other side. But so far, I've not had to operate on the other side of almost all the ones that I've done. They are holding out. And so the outcomes are very good and very satisfying. And pediatric tissue is so beautiful. And as I said, we go in by VATS and we just take it out, and it's a fantastic operation in kids to operate. But technically more challenging because of the adhesions, because the blood vessels lose the perivascular space. So it's not as simple as putting an instrument around the blood vessel and scooping it and putting a stapler. So you do need to be more patient, and you do need to take your time over it. But yes, pediatric is very satisfying, actually. So thank you very much, Dr. Yusuf. There has been huge response from the audience. Everybody is congratulating you on a fantastically delivered lecture. I second that strongly. I thought it was a brilliant lecture, very well thought out and very well laid out. And I love your style of delivering the lecture. And the way you took the question answers was amazing. So thank you very much once again. We are really grateful for you having given us your time for this lecture. And I'm sure the youngsters in the country, not only in India, but we are beaming at the moment to 10 countries or 12 countries actually, as I see the feedback on my screen. And everybody's been appreciating the wonderful talk that you gave, sir. Thank you very much, and good day to you, sir.